and then we'll get started with our meeting. Love to see all these people. We're so happy. It's been a really long spring. Hi, Catherine Snedeker. Welcome to the meeting. This is the April meeting of the I'm going to be the tech person today and pass it off to Dr. Eve Valera, and I'll jump back on as needed. So, Eve, would you like to take the meeting?
So hi, everybody. Oh my gosh, this is super amazing. Look at all these people. Wow. Oh, I am super excited. I just want to reinforce to my wonderful students that this is an extremely friendly group. Looking through to see who's here. Oh, it's really super cool. Oh, I'm so glad Paul's here and Lori. Oh my goodness. Wow. And Althoff and Hirsch. Okay. This is fabulous. All right. I don't want to waste too much time saying, oh, and Kathy and Lynn, of course, and Nick. Oh, and Skylar. All right. Well, I don't want to I can't name everybody, but welcome everybody. This is super exciting. I'm Eve, and the two presenters today are Isha and Aylin, who are members of my lab. They've been interns, and I'll tell you each of them about each of them in just a second. But I just want to say, I don't know if anyone on the leadership team has any updates that they wanted to make or felt they needed to make. If so, I'll give people an opportunity to do that now because I do see I think I heard Angela was on. I think Lynn, does anyone have any updates they want to make? And I know Kate was gonna come, but she said she might be a smidge late. Okay, I don't see an update. So without further ado, if you do, just raise your hand or let us know. This is super exciting. I am really excited about this session because basically both Isha and Aylin have done this work as undergraduate interns in my lab. Isha has been working, she basically worked with me all the way across the continent, basically, because she was in California doing her work, and Aylin was more local. But I'll just introduce. So Isha is actually on her way to medical school at Stanford University School of Medicine. She also got into Harvard Medical School, by the way. So she's one of those, right? Brilliant, nice, wonderful, and also, finding time to do things in the lab that she felt passionate about. She studied neuroscience and social entrepreneurship at the University of Southern California, and then she graduated valedictorian in 2023. So it's been an absolute pleasure working with her, and she's going to tell you about some of the work that she's done in our lab. And so currently, like I said, she's serving as a clinical research intern. And I'm going to introduce both of the speakers because, as many of you know, I actually have to always go get my kid at 2:25. And then people get nervous because I try to talk on the call and they're afraid I'm going to crash. So I'm not going to talk on the call, but I'm going to go get them. I'm going to be listening on my phone and then I'm going to come back. And so I'm going to introduce the other speaker too, who is Aylin Tanriverdi. And she's actually a junior at Harvard College studying neuroscience and chemistry. And she's been part of my lab since the fall of 2021. So I don't know. I don't know what keeps her here, but I hope it's a good thing. So, but she's been absolutely wonderful to work with as well. And she's been focusing on how psychological abuse and brain injuries might affect later cognitive functioning. She's helped me conduct trauma-informed interviews and screenings and assisted with neuroimaging scans and stuff. So she's been really great. So without further ado, I'm going to I'm going to have Isha, I think, go first. And then what we're going to do, so that I don't have to try to moderate a Q&A in the middle, we'll kind of go to Aylin and have the questions afterward, hopefully when I'm back. Okay. So I think we just need to, oh, I think you probably have screen sharing capabilities, Isha.
Yes, I
Is
already
that right?
turned it on.
Thank you.
All right. So thanks everybody for coming, and I think you're in for a real treat.
Everyone can see my screen. Okay, awesome. Thank you, Dr. Valera, for that very kind introduction. That was very sweet. Hi, everyone. My name is Isha. Very excited to be here. I've worked at the Valera Lab for the past, I want to say 1.5 years now. I started in college when I was at USC, but I currently work as a post-baccalaureate intern. And like Dr. Valera said, I'm on my way to med school at Stanford, and I'm very interested in trauma-informed care, especially in the ways physicians can provide trauma-informed care. So I think that this research experience was probably one of the most transformational personally because it shows me how much more is needed as a physician, even beyond just research in the ways we interact and help our patients. But in terms of kind of what I'll be sharing with all of y'all today, I'm really excited to be talking about kind of our recent qualitative study and some of the insights there, more specifically, kind of focusing on how we can understand brain injury in the context and the voices and words of survivors themselves, just because there has been a lot of quantitative research that has really established kind of the importance of looking at brain injury in intimate partner violence. But there has been less research on kind of using the voices from those who've experienced it kind of firsthand. I wouldn't have been able to do it with this incredible team. So Sarah Rose is currently at optometry school and kind of we worked on this together. We've also been getting a lot of incredible feedback from Dr. Thedum and Dr. Chua. Yeah, kind of before I get into this, and I know that this crowd is far more familiar with this than I even am, but I think it's helpful just to establish some common ground for the people who are watching it and may not know as much of it, just to kind of establish some sort of definitions. So when we think about intimate partner violence, right, we're thinking about violence that's perpetuated by a current or former spouse, partner, significant other, kind of usually within the context or the sort of the context of a romantic relationship. And when we think about intimate partner violence, kind of we as a group understand sort of the pressing need to be thinking about it because it is the leading cause of homicide for women globally, the most common form of violence against women. And also, I think this is especially important found across all socioeconomic boundaries. And so when we think about the fact that 1 in 3 women experience IPV, there are definitely certain populations of individuals and women that are more predisposed to experiencing intimate partner violence. But that being said, kind of everyone is vulnerable to this experience. And so we should be thinking about it in kind of a broader terms. I will say kind of one of the big strengths of doing a qualitative research study was our ability to speak to individuals who might be more predisposed to intimate partner violence and traumatic brain injury, whether that was individuals experiencing homelessness or individuals whose English was their second language or they were facing tricky kind of immigrations. And so we are both able to kind of get a breadth of that understanding for women's experiences, but also sort of legitimize some of the experiences that we don't see as much in research. Yeah. And then kind of it's already been established that, right, 80 to 90% of these injuries to women are experienced or targeted towards the head and neck, which kind of gets us more into this specified funnel of traumatic brain injury. And kind of Dr. Valera has already done some incredible work that's sort of established sort of the scope and prevalence of traumatic brain injury across women who've experienced intimate partner violence. I'm kind of speeding through these just because I know that this is kind of common shared understanding amongst all of us, but just in case there's someone who's watching this, they're also able to access the information. But yeah, 74% of kind of these women have experienced at least one intimate partner related brain injury. But then from there, we have around 50% experiencing multiple. And so it really does establish kind of this clinical significance that we do need to be thinking about within brain injury. I think common understanding oftentimes makes us think that it's just kind of a select few or a specific slice of women who've experienced intimate partner violence that are also experiencing brain injury, but there is a huge scope that kind of we've already established. And kind of the final slide, just in terms of establishing some context. So, like I said before, this was Dr. Valera's research back in 2003, but there have been already, I think, a good movement of establishing quantitatively what IPV-related brain injuries look like in terms of those cognitive, psychological outcomes, what does the neuropathology look like, et cetera. But that being said, I do think that there currently lacks really a nuanced understanding of what women who've experienced this intimate partner violence, traumatic brain injury, understand about their own injuries, and then also kind of their own decision making to receiving healthcare, right? Because our ultimate goal is ensuring that women who have experienced, I mean, of course, prevention first, but for women who have experienced IPV related brain injuries, how do we encourage them to have that brain injury diagnosed, appropriately treated, And because the experiences of these women that we've noticed from kind of our qualitative research is so complex, there are so many factors outside of just their physiology that prevent them from necessarily accessing their care, both personally as well as within the healthcare system, that if we're not able to accurately kind of take down in the literature and in research, we're not able to actually improve the ways in which these women are receiving care. So that was kind of the main priority and purpose kind of going into it, is both understanding their experiences within the healthcare system, also their own experiences coming to terms with the fact that they have a brain injury from IPV. So in terms of our methodology, we recruited 16 female identifying adults who are all previous study participants, and they all consented to being interviewed. And in terms of the actual interview itself, it was kind of a minimum of a 1 hour interview. It often went a little bit further than that. We didn't really want to limit women who, I mean, for many of the women we spoke to, it was both incredibly therapeutic to be able to talk about a lot of their lived experiences. And so, yeah, we conducted a virtual interview for an hour with each participant. And the important thing to kind of keep in mind here is that while we had some kind of questions that we did want to get in terms of standardizing sort of the takeaways that we could get from these 16 different interviews, we didn't necessarily have like an actual framework. We didn't have a predetermined framework we were using to analyze any of the interviews, because if we were to use a predetermined framework, we wouldn't be getting a lot of the nuanced understanding that comes with just letting women kind of authentically speak about their experience and letting them have ownership and autonomy of the conversation. Um, so in terms of kind of post-interview, the interviews were transcribed and then analyzed independently by 3 different individuals. And so we independently kind of came up with a set of different themes that we found came up multiple times across interviews, and then worked together to sort of consolidate them in the themes that I'm sharing with all of you. And again, no predetermined framework was used. I think this was especially important because there were so many experiences that we were able to capture that might not have otherwise been captured if kind of we were asking questions that we thought were important. Because right, we don't know what we don't know, and I think that that's the beauty of using a research project that lets the participants themselves guide the discussion. And so in terms of the themes that we got kind of from these different conversations, I think it's helpful to sort of establish a continuum of an individual experiences a brain injury from intimate partner violence. And then kind of at the end of the continuum, our goal is to hopefully have them engage in the healthcare space, have that brain injury diagnosed, and then appropriately treated. But there are multiple different barriers along the way and multiple different experiences that we were able to pick up on. So for example, we thought a lot about what was the actual experience of head and neck injury following intimate partner violence, and kind of from there, what was the patient's own understanding of their brain injury, and kind of what were the different factors that either compelled them to seek healthcare or prevented them from seeking healthcare. And then finally, kind of once they did actually decide to seek healthcare, were they compelled to disclose their kind of the real root cause of how they sustained their brain injury, and what did those conversations within the healthcare setting look like? And so kind of in terms of that first theme of right experiences of head and neck injury, I think one of the things that we thought was particularly interesting was the fact that for a lot of the participants that we spoke with, it was difficult for them to determine if their experience of assault and abuse was actually considered intimate partner violence, and by extension made them less likely to even think about kind of their brain injury because they were so preoccupied with kind of the IPV. So for example, kind of we spoke with one participant, and kind of as I go through this, these are actual quotes that we got from our interviews that you're able to kind of read along with and hear in their own words, in addition to kind of my summary of their experiences. But thinking about situations in which an individual was engaging in consensual BDSM, and then afterwards kind of things took a turn for the negative, and they experienced intimate partner violence. But it was difficult for them at the time to really untangle the two because it had started as a consensual experience. And so kind of these different experiences made it difficult for women to even distinguish whether or not what they were experiencing was intimate partner violence. And kind of from there, the main thing that we heard kind of repeatedly from different participants was that brain health was not a priority at the time of their injury. There were multiple competing priorities that they had. So for some of them, we can kind of triage it into different root causes in terms of why brain health wasn't a priority at the time of the injury. For some of our participants, like you'll see in this kind of account from one of our participants, they had children that they were really preoccupied with making sure were safe, or they were focused on their own safety. And for a lot of them, they hadn't even really acknowledged acknowledge that the injury that they had sustained was going to have some sort of negative effect on them in the long run, right? Because all of these interviews, when we're asking about their experience at the time of injury, ask the participants to retrospectively reflect. And so when they're retrospectively reflecting, kind of they have the knowledge at the time of what that brain injury did in terms of symptoms or psychological outcomes. But at the moment in which they actually kind of sustained that brain injury, didn't think it was important enough to access healthcare. And then in terms of kind of patients' own understandings of their traumatic brain injury, there were definitely mixed kind of self-reported patient understandings. And what I mean by this is that we found that because brain injuries can be so invisible and they don't manifest themselves in the way other injuries might do, it was very difficult for women themselves to sort of differentiate between whether or not their symptoms were because of a brain injury or whether or not it was because of the psychological stress of the event that they just engaged in, right? That they just experienced because of the intimate partner violence. And so this is, I think, a quotation that really captures is, I didn't know if I was dazed because I hit my head or because I was shocked at what happened because that was the first time I ever got hit. And so because there are so many different experiences that you're trying to untangle, a lot of the women reported not knowing if their symptoms were actually a brain injury. Was it psychological trauma? Was it stress? Was it just natural aging? And so because of that, there was also less of a priority to actually specifically get their health checked out because they thought this might just be a normal byproduct of the experience. Another thing that kind of we understood from this in terms of not being able to untangle the root cause, whether it was psychological or physiological, was the fact that most every participant we spoke with had kind of availed therapy at one point or was currently going to therapy to treat their psychological symptoms, whether that was PTSD, trauma, etc. But very few of them actually went to a hospital system or a healthcare setting to kind of address their physiological symptoms. And so there was kind of this implicit understanding or implicit prioritization to focus more on those psychological effects than the actual brain injury itself. And then kind of from there, another interesting thing we found was that a lot of individuals, their kind of understanding of traumatic brain injury came from the media or came from sports, came from kind of what we canonically understand or like we talk about in terms of traumatic brain injury, whether that's contact sports, the military, and because that was their understanding of traumatic brain injury, they were comparing their experience to that framework and it wasn't congruent. So they didn't think that what they were experiencing was a traumatic brain injury until far later, which really, I think, kind of contributes to this idea of there needs to be an increased sense of awareness or education at the time in which a woman is experiencing their brain injury or will experience that brain injury, because all of these kind of realizations are done way past the actual instance of injury itself. And then kind of finally from there, we were also able to sort of compile the different barriers that women sort of reported in terms of whether or not they decided to seek healthcare. And so these were kind of the three big themes. And I don't think any of them necessarily come to a huge surprise to us, but it is good to kind of validate and understand that the themes that we understand as preventing women from seeking healthcare are also the themes that the individuals themselves are reporting as a huge priority to them. So the first one was kind of these internal feelings of shame, guilt, and fear. So, fear of repercussions from the legal system or losing custody to their children, cultural shame. One of the benefits of this qualitative study is we tried to be as diverse as possible in terms of the kinds of participants we were including. And so, a lot of different individuals we spoke with talked about kind of the different cultural barriers that made it difficult for them to even acknowledge or kind of unpack the shame that they had experienced. And then also a lot of self-blame. From there, I think one of the other interesting things we picked up on was, again, this idea of brain injury isn't visible, but when it is severe or when it manifests themselves in bruises on the neck or kind of very phase symptoms, oftentimes because of those very sort of visible injury symptoms, women would then feel more confident to actually avail healthcare. So one of the women we spoke with had mentioned that she wished her symptoms or her injury was a lot more severe or visible because she would have felt like she could have justified it both to her partner and herself that she should have sought healthcare. And then finally, many perpetrators often prevented kind of access to resources and care. So kind of all of these combined made it very difficult for a lot of the participants we spoke with to decide to seek healthcare. Another one here that we didn't put on the slide, but is also important to recognize, is the fact that many of the participants we spoke with felt that that going to seek healthcare when their brain injury wasn't even a priority at the time. They weren't sure that that was actually going to help their situation. They didn't feel like accessing healthcare was necessarily going to be the strongest solution. Instead, the best solution was just trying to figure out how to get to a safer place. So again, this idea of what are the competing priorities at the time of injury. And then I think this is quite possibly one of the most important themes to unpack because it isn't as much discussed in the literature. While kind of barriers to deciding to seek healthcare has been something that we have been validating, is kind of for women that have sort of made it past that funnel, have decided to seek healthcare, talk to a physician, talk to a provider. Are they actually disclosing their IPV, or are they just trying to get healthcare support for their injuries? Right. And so, kind of from there, we found that the majority of the women did not disclose their intimate partner violence or, the actual real reason behind their brain injury to healthcare professionals. And there are multiple reasons for this, but largely kind of they boil down to this idea of the healthcare setting being somewhat hostile and not trauma informed. Whether that was in the way questions were asked, the setting in which questions were asked, the time and space allotted to participants. And so many individuals, kind of when we think about what that question looks like in the healthcare space, it often boils down to, are you safe at home? And a lot of individuals felt that that question wasn't adequate enough in making them feel comfortable to disclose, because it was often said with their abuser in the room, it was said with participants or other patients nearby them, or it was said in a way that made them feel like even if they had kind of honestly answered, there wouldn't really be the time and space to unpack that with the provider they were working with. And so this is kind of an example of a woman we spoke with whose abuser was in the room when the provider had asked that question, and so felt very uncomfortable giving an honest response to it. And again, kind of getting to this idea of, self-blame, shame, and guilt. Not only was there kind of experiences from the healthcare setting forward, but there was also internal experiences or feelings from the participants themselves of feeling that their own behavior was unacceptable, and that made disclosing difficult. So whether this was feeling cultural shame, religious shame, etc., this often made it very difficult to actually feel like they were comfortable enough explaining it to someone else because they felt like it would be met from judgment, etc. We also spoke to a couple of participants who were previously unhoused and experiencing homelessness, and they felt that their experiences in the emergency room contributed to this idea of not only internal shame, but feeling like they would receive judgment from healthcare professionals if they were to reveal the truth about their intimate partner violence. Um, and so I think the larger question that kind of we're thinking about when we have all of these different kind of themes and findings is, how do we consolidate the stories and the data to both improve the healthcare system as well as improve the rate at which these women are able to actually confidently get their brain injury diagnosed and treated, etc. And so kind of some of the preliminary thoughts we've had, and these are all thoughts that were shared by the participants themselves, because every interview ended with the question of what do you wish you had, or what do you think would actually improve kind of the current situation. And so these were sort of the big ones that kind of we found overall. And so first one was trying to include more consistent brain injury screenings, so it felt like the onus wasn't on the participant to feel like they had to disclose this brain injury, but rather having physicians be equipped with sort of a set of tools of sort of noticing if this individual meets these different qualifications and we sort of suspect intimate partner violence, we suspect brain injury. The onus is more on the physician rather than the participant themselves, was something that was mentioned. Um, Also, more trauma-informed training for providers was a huge one. Whether this means changing the questions we ask participants themselves in kind of the emergency room or in the hospital setting, or including more social support and social services for participants who are suspected of experiencing intimate partner violence. This was, I think, a really big one for a lot of participants, and that feeling like we have sort of nurses for sexual assault exams and trying to incorporate more of kind of having specific people who are very trauma informed that they felt comfortable kind of going to for resources. Some of the women who actually did disclose their IPV to their providers felt like even after they disclosed, their providers were supportive, but didn't actually offer any tangible resources kind of moving forward. So they also felt like that contributed to their sense of like hopelessness about getting adequate support from their provider. And then generally, I think this was mentioned in every single interview we had about increased community awareness, resources, services, beyond just kind of digital services. Are there ways to include community centers, sort of print analog resources in the hospital setting? Because a lot of like perpetrator control involved technological control. So being very aware of the different barriers that the women and the participants themselves have voiced and using that as an opportunity to redesign the way we do community awareness, not just increasing the number of websites we have, but increasing the number of different ways in which women can access these resources. So thank you so much for taking the time. Very excited to hear if anyone has any thoughts. I have my email at the bottom. So if anyone has any thoughts or any questions, excited to talk about it later, but would also love if you just shoot me an email and we can chat from there as well. But thank you.
Great presentation. Thank you so much. We did have one comment that I'm reading in the section that I thought would be interesting. Kathleen Monahan, would you mind jumping on just for a minute or two and just talking about the word trauma responsive? If you can.
I was trying to find my unmute. Usually my family is always looking for the mute button for me. 9/11, when 9/11 happened, over 20 years ago, we all became trauma informed. Everybody knows what PTSD is. Everybody knows what trauma does to people. So now we need to step it up a level and become trauma responsive. So everybody, taxi cab drivers, everybody's trauma informed. They know what trauma is. They know basically what trauma does to people, how common it is. So for clinicians, researchers, we need to use a new language that addresses the fact that not only are we trauma informed, but we can respond to traumatic situations and people who've experienced trauma.
Thank you for that comment. Eve, I see you. Do you want to jump on and say something, Eve?
I was just going to say that was awesome. And I hope we get more questions. I want to make sure we give Aylin an opportunity to speak because Eileen's going to talk about something totally different. So we have more questions at the end. Can you hear me?
Yeah. Yes.
Oh, okay. Aylin, are you ready?
Yes, I can go. Well, first of all, I just want to, Isha, your presentation was amazing, super important work, and you explained it so eloquently, and your slides were amazing. So thank you so much for that amazing talk. I'm going to share my screen. All right. Can everyone see my screen? Okay. Awesome.
Looks great.
Thank you. Great. Thank you. So today I'm going to be talking about IPV-related brain injury, psychological abuse, and partner support in relation to cognitive functioning. So this is more of a quantitative study as opposed to a qualitative one. I guess before I get into it, just to introduce myself, my name's Aylin, and I'm a junior in college that has been working in Dr. Valera's lab for the past 2 or 3 years or so. Yeah, and I'm very excited to be speaking with y'all. Thank you so much for inviting me. So just to give a quick overview of the findings, just an overall summary before I dive into the details, we found that after controlling for previously studied determinants of cognitive function, IPV-related brain injury was associated with decreases in some dimensions of cognitive function. and partner support was associated with some improvements, but surprisingly, psychological abuse was associated with some improvements in some cognitive function dimensions as well. And exploratory analysis suggests that it might be related to partner support and opportunities for recovery, which I will get into. So just to motivate the study, so as Isha very well explained about IPV and brain injury, Dr. Valera has a study from 2003 where she looked at IPV-related TBI severity and cognitive function. And that study was done with women in shelters, but there hasn't been research on this relationship in women in the community who might be experiencing a more stable lifestyle, who might be out of the abusive relationship and have perhaps started new relationships that are more supportive. And so they might have broader relationship dynamics. And so in this study, we're interested in looking at this relationship in community women and also looking at the role of partner support in cognitive function. In terms of related literature, previous literature on this topic, Dr. Valera's study from 2003 found that IPV-related TBI severity was negatively associated with memory, learning, and cognitive flexibility. And there have been other studies that suggest that it's common for women to experience multiple forms of IPV, and in fact, experiencing multiple forms such as physical and psychological IPV has been found to be associated with poorer average flexibility scores compared to facing psychological IPV alone. But the study that looked at that relationship excluded participants with brain injury, whereas the Valera study with TBI severity and cognitive functioning did not account for psychological abuse. And so it points for a need to study both brain injury and psychological abuse together because previous studies have not looked at them in combination. And so in this study, our aim is to look at in women who have had past physically abusive relationships with varying levels of psychological abuse, we look at how the number of IPV-related brain injuries, psychological abuse levels, and partner support levels are associated with cognitive functioning. We initially hypothesized that higher levels of brain injury and psychological abuse would be linked to poor cognitive functioning, whereas greater partner support levels would be associated with better cognitive functioning. In terms of our sample characteristics, we had 107 people after excluding for mild brain injury within the past 3 months, any history of moderate to severe brain injury and convulsions, epilepsy, and stroke. 64% of our sample was employed. Average years of education was 16 years, which is roughly college education. The average age was 39 years. In terms of our measures that we used, our primary outcome measure was cognitive functioning, which we used a previously validated computerized neuropsychological test battery, CNS vital signs, which measured different aspects of cognitive functioning. And we also had a number of brain injuries measured using Dr. Valera's brain injury severity assessment, psychological abuse using CTS, and partner support using CTS negotiation subscale. And we modified those to capture lifetime levels of psychological abuse and partner support. For our covariates, these were what we controlled for, including psychological variables like PTSD, anxiety, and depression, childhood trauma, alcohol use in the past year, chronic drug use, as well as psychotropic usage currently, education years, and employment status. In terms of our results, we found that higher numbers of IPV-related brain injuries are linearly associated with slower reaction time and poorer visual memory, but we did not find significant associations in IPV-related brain injuries and the other dimensions of cognitive functioning. For our psychological abuse results, these were surprising. We found that higher levels of psychological abuse were linearly associated with faster reaction time scores. We found a curvilinear inverted U relationship between psychological abuse levels and verbal memory. So low to moderate levels of psychological abuse were associated with higher verbal memory scores, but after a certain point, from moderate to high levels of psychological abuse, verbal memory scores were decreasing. And we also saw a trend in terms of executive function with psychological abuse being linearly trending towards higher executive function, but that did not reach the significance threshold. We did not find associations with the other cognitive dimensions. And so these results were very surprising, and we need more work, more studies to be done to figure out what might be explaining those, but we did consider potential explanations. One we considered was hypervigilance, but we found that psychological abuse does not predict hypervigilance, and hypervigilance does not correlate with reaction time. However, it does trend with higher verbal memory scores. But even when we included hypervigilance in the model, we still saw these same results with psychological abuse and reaction time and verbal memory, which suggested that hypervigilance might not fully explain our surprising findings. And so we considered other explanations, such as coping strategies and cognitive resilience. It is possible that women who have experienced more abuse may have sought activities to cope with or escape the abusive relationship. And during our intake interviews, participants actually commented things like, "What didn't kill me made me stronger," which supports this potential explanation. And it's also important to consider the characteristics of our sample. A lot of them are no longer in abusive relationships, have integrated into community life. On average, their last psychologically abusive incident was 5 years ago. 64% of them are employed now. And more qualitatively, during interviews, participants mentioned engaging in activities like arts, design, meditation, IPV advocacy, or starting new families, which suggests that they have left the abusive relationship and reintegrated into community life and rebuilt their lives in ways that are meaningful to them. And so we wanted to test this potential explanation a bit more. We definitely need more work to figure out if this is actually what's going on, but with the data that we had, we still tried to do an exploratory analysis. So we specifically looked at partner control and partner negotiation and how that might influence this relationship with psychological abuse and cognitive functioning. So what we did is we created subgroups of people who had really controlling partners and less controlling partners. We looked at psychological abuse and reaction time. We found the same surprising results in the group that had less controlling partners, but we didn't see these results in the group with more controlling partners, which might suggest that, if the partner is being very controlling, maybe they're limiting potential opportunities for recovery, so we don't see that improvement in reaction time. And as Isha was mentioning about partner control in her qualitative study, it's possible that with partners that are very controlling, they may be preventing access to resources and care. And we also looked at partner support as measured through the CTS negotiation scale. And we separated them into women who had very supportive, like relatively more supportive partners and less supportive partners. And we looked at the relationships, and we found these same surprising results in the group that had supportive partners, but not in the group that had less supportive partners, which suggests that if the partner is not being very supportive, it might suggest that they're limiting the opportunities for recovery. And so we don't see this surprising improvement relationship. And so these results just are exploratory, and they suggest that potential support for this resilience potential explanation, but we definitely need more research to understand what is going on. And we also studied partner support and cognitive functioning. We found that higher levels of partner support are linearly associated with faster reaction time scores. And so in summary, we found that higher numbers of IPV-related brain injuries were associated with slower reaction time and poorer visual memory. That should say visual memory. I apologize for that typo. And we've also found, surprisingly, that higher levels of psychological abuse were associated with faster reaction time scores and display a curvilinear inverted U relationship with verbal memory. And we find that higher levels of partner support are associated with faster reaction time. In terms of our limitations and future research directions, so this study lacks pre and post abuse measurements of cognitive functioning, so future studies should do longitudinal research to look at how women's cognitive function changes before and after IPV exposure, as well as examining factors that might influence that trajectory, like post-traumatic growth, social support, and other coping strategies. Another limitation of our study is that our partner support measure does not distinguish if the partner support is coming from the abusive partner or from a different partner, like a new partner that the person might have had. So future research should address that distinction as well. And there's also a need for further qualitative research, like the amazing study done by Isha and Dr. Valera and colleagues, to explore personal narratives of struggle and resilience in women who have experienced IPV, to look more deeply into what might facilitate or hinder their well-being. And overall, these findings will be important to develop more effective interventions, support, and resources tailored to the needs of women who have experienced IPV. Thank you.
Awesome presentation. Are you available?
Thank you, Aylin. That was awesome. So I want everyone to know that I invited both Isha and Aylin to do this mid-week last week. So they were able to put this all together in that amount of time. So as you can imagine, usually you would have, I might have them do a practice run or things like that. And crazily, I said, you know what, I trust these two and I think they can do it, even without a practice run. And so they did it. So I'm super proud of them. And we are really, I think that if I would love to hear any feedback or thoughts you have on any of these data or your comments, because we are actively in the process of analyzing these data and writing these things up. So if you have any thoughts or ideas, that would be great. But I honestly couldn't be prouder of these two. And yeah, I'll let the audience have questions now.
Eve, do you want some of the questions from the chat throughout the session?
Sure. However it works.
Are you back home? Can you see the screen?
I'm almost there.
Okay. I was tracking
so
one of the questions from the chat was, could you provide demographics of the participant in terms of race and educational background, and were they all English speaking?
Yes, that's a good question. I'm in the middle of kind of compiling that data, so I'm happy to send it over later as well. They were all English speaking. The main thing is that kind of we included in terms of our decision as to whether or not to reach out to the participants, where we were trying to get kind of a diversity in the number of brain injuries that these different participants had experienced. So some folks had experienced 1, some folks had experienced upward of 5, and also kind of a diversity in like housing status, ability levels, as well as kind of race, ethnicity, etc. I don't have that data on me right now, but I'm happy to share it when I finish compiling it all.
And another question for you was, did you do member checking in your analysis? Which I don't even know what that is.
Yes, I mean, I would love if anyone who I think brought that up would like to share some more background about how is best to do that. I think from my understanding, member checking analysis is taking these like compiled themes that we have found and going back to the participants that we've spoken with to validate that this does accurately capture what they have mentioned in the interviews, which wasn't something that I think was on our radar, but I would love to talk to the folks who mentioned that, because I think that would be very important to do.
Shireen mentioned that, if I said your name correctly.
Hi, excuse me, sorry. Yeah, this is Shireen. Yes, I did mention it. And yes, you explained it correctly, to take the results or even the transcript sometimes and share it with the participants to kind of get that validation and see whether your interpretation is on track. And yeah.
Would you show to the participant only their transcript, or sort of a selection of transcripts across the people that were interviewed?
Generally, you show the transcript of that participant, but you can also share your results. And I think that's really powerful, where they can say, yes, you're right on track here, or they might have a more nuanced understanding of what the issues are, and they can greatly help in kind of giving context and making your findings more robust. And again, it depends on the survivors, right? And so some of them may not want to deal with it because you're really getting deeper into the topic. And so you kind of want to be very trauma informed or trauma responsive to make sure that that is something that they are interested and willing to do.
Sounds good. Thank you for offering that, Shireen. I appreciate your insight.
Oh, no problem. Get in touch with me. We do a lot of qualitative research as well with
Awesome.
IPV survivors who are at high risk for brain injury. So yeah.
Thank you.
I think that's awesome, the discussion. And I just interviewed John Corrigan from Ohio State, and he's using the term brain health informed. The way we talk about trauma informed, hopefully we can start using the term brain health informed. That, when we are talking as professionals or researchers, do we understand the brain health of the person that we're talking to from a brain health perspective? So I love these new terms. That's great. Eve, did you want to say something?
I am technically home. Just so in case you're worried about me, I made it.
Excellent. I must say I gave a little concern to Eve talking on video and driving. Paul, you've had your hand up.
Yeah, thanks, Catherine. Great talks from both of you. Fantastic information. I have a question from Aylin's presentation around the interesting finding, faster reaction times for folks who've experienced higher levels of previous psychological abuse. One thing that came to mind as another potential explanation is the idea around being activated by answering questions related to previous experiences of intimate partner violence as part of the overall questionnaires that were being done. And there's, I think, some good evidence that activation in general can lower reaction times as long as it's not too high. I don't know that it's something you could pull out with an additional exploratory analysis, but it might be something worth considering. I suppose one way you could get at it is to set up a context in which you activate them more or less and see if their reaction times go up or down and correspondingly. Anyway, just a thought. Excellent presentation.
Thank you so much for that potential explanation. Yeah, in our study design, we start with the cognitive function test before we ask any questions about their abusive relationships. So that is one way where we try to, reduce like the bias of, having them like recall the abusive relationship, having that influence reaction time. So that's one way that we try to account for that. And maybe I like misunderstood or misheard you, but we actually found like higher levels of psychological abuse were associated with faster reaction times. Okay, I think sometimes when we say like lower or higher, it can be a little confusing, but I just want to make sure. Okay, great. Yes. So thank you for that suggestion though. It's great.
I'm going to raise my hand really quickly. So Paul, so I know you've done some work kind of generally in this area. Have you found anything like that at any point? Not
in IPV participants, but in young athletes that we expose to some activating sort of context, you generally see improvements in performance as long as it's not too big an activation. And activation could be anything. I mean, in the case of the young athletes, it was a 20-minute bout of soccer heading. And we were expecting decreases in performance, and we actually saw some improvements in performance because they were activated. They were, their blood was flowing, their heart rate was racing. They just done an activity they loved, and that caused them to get a little bit better at the task we were assessing them on.
Interesting. Yeah. So your idea was really good, but I don't know if we can count that. Okay. Well, thank you so much. I appreciate that. Who else has questions?
I see someone unmuted. Please go ahead.
I just wanted to say, it's not a question, but I just wanted to say how nice it is to see that focus on qualitative work. As another qualitative champion, woohoo! Great job. Keep going.
Thanks,
Thank
Lynn.
you. I appreciate that. I had a quick question. I think this kind of gets back to like the power of language in our qualitative study. I was curious if folks had opinions on, for example, using the term survivor throughout the paper, because I know I've heard kind of different opinions from participants themselves as to like the undue pressure that puts on them as to like what their sort of their journey of recovery has looked like. I know I used it in the title, so I was actually just curious if anyone had any opinions there, because this is probably the best group to ask it to.
I use survivor as well. And part of what I get is the same sort of challenge around that, but also the repetitiveness of it. You know, it becomes really sort of onerous. I will often flip it up with persons exposed to intimate partner violence. So it changes that sort of dynamic a little bit. And I think moving forward, one thing that you can do is ask participants, what language would they like and what are they comfortable with? I think anytime that we offer folks the opportunity to label themselves rather than us applying that from a top-down perspective, I think that's a great thing.
Yeah, I think I agree. And that's one of the reasons why I always use women who have experienced intimate partner violence, because I feel some people want the term survivor. Some people, they do like the term victim because they're like, well, you know, I was victimized. You know, this is, you know, and if you're in a legal setting, it's also the term that you really have to and want to use, you know, to help increase the likelihood that you'll get what you want. But yeah, I don't think I've determined what the best term is either. But yeah, so in an individual setting, you're absolutely right. That's what we should do. For writing a paper, I kind of take the easy way out so far, but I'm always open to new suggestions, because that is a mouthful. Women who've experienced partner violence, intimate partner violence, every time. But yeah.
And Lynn, we're hoping to have you present in one of the next 2 meetings before we break for summer.
Happy to, Catherine. Yep.
Do you want to announce now which month you want to do it, and then people can know?
I can do either May or June, whatever works for you. So you can use me as backup and see if you've got somebody else. I know you were thinking about Michelle too from Australia. So.
Well, you'll have to check back in. We have about 2 more minutes, and then you'll have to see when Lynn speaks in our May meeting or our June meeting, and then we'll have a break for the summer and be back in September. So we probably have time for one more question if there's somebody out there. There are tons of compliments in the comment section, and I will save those and send those to all 3 of you so you can see if you missed something along the way. But wow, fabulous presentations for just less than a week to pull it together.
Yeah. Congrats to both of you, Aylin and Isha. You did a great job.
I have one quick question. Is this published at all yet? Can we actually get copies of some of this?
No, not yet, but it's in the works actively, very actively.
Okay, then when I need to know something, I know who to ask. Thanks.
Exactly. Well, happy to
We did record this, so when I get around to doing video editing, maybe this weekend, I will have it up on our YouTube channel with all the other presentations we've had since 2018. Well, thank you, everybody. Thank you, all of you for showing up today. It's a great group, and everybody stay safe, and thank you for the presentations. Thank you, Eve, for asking the students a last minute, and it didn't seem like students to me. You guys seemed like researchers, so great job, and I'll see you all next week. Eve, you want last words?
Yeah, no, thanks. Thanks so much to everybody for showing up and listening and sharing. This is, I will say that this field was not really a field. I mean, like definitely not 25 years ago. I'd say not even 10 years ago. And now we really have a field. It's really exciting. And, you know, to see people interested and continuing to be interested, it's just, you know, it's why we do this, because we know we're, you know, making a difference. If we do the work and no one listens, it doesn't really matter, right? So it's really awesome. And yeah, thanks so much for showing up. And thanks so much to Isha and Aylin, rock stars. Woo!
Rock stars. Thank you all. Take care.